Hello and welcome back to another episode of Taking Control of Cancer, the podcast brought to you by the North East London Cancer Alliance. I'm Steve Bland, and as ever, we want you to think of this podcast as a how-to guide to help you overcome some common myths, some fears, some barriers when it comes to cancer prevention, diagnosis, treatment, and care. However you're impacted by cancer, we want to help you take some control. And a big theme in this podcast so far has been how collaboration between different people, between different hospitals, different organisations has been really key to taking that control. And so this episode is all about that collaboration, why it's so important, and how we achieve it. And to do that, to actually explore collaboration, we're going to get to know a man who's popped up in several episodes so far. He's the managing director of the North East London Cancer Alliance. It's Femi Odewale. And I've been chatting to Femi all about his role, all about his background, how he came to work for the Alliance, and why he feels this role is so special and so important. So Femi, we've had loads of conversations in this podcast series, but this episode is all about you, and I want to find out all about you. You know, what's brought you to this point, what your role involves, what you're working on, what drives you, what your passion is, and some of the things you're working on going forward in the future as well for the Alliance. So let's start right at the very start. How did you come to be in this fantastic role?
It is a fantastic role, I must say. I have worked in the NHS for close to 20 years now. I'm showing my age. Close to 20 years, and I have somehow worked in the field. Everything I've done has got something linked to cancer. So I started working. So I was an operational manager before. Predominantly worked in secondary care sector. So predominantly inside of the hospitals. And I've managed several different portfolios from medicine to surgery to the surgery divisions to surgery and the cancer. Whatever it is that I've done, there has always been an element of cancer. So it's a area or a topic that cuts across every single health speciality in the way that health specialities are kind of designated for management within the NHS. So by default, I've ended up here, but I've always wanted to end up here, to be honest with you. So whilst managing surgical divisions and medical divisions, I've worked very closely with cancer alliances in the past. I helped with, it was only me, with other colleagues to set up the Southeast London Cancer Alliance when they were first set up. I mean, it had different shapes and sizes before that, but I think the alliance is a perfect shape. So I supported there. I worked over in Mount Vernon as well as a cancer. I was the director for cancer service, well, cancer for the whole of that hospital at one point as well. So I worked very closely with a colleague of mine, a very good friend of mine called Karen Brown as well. She was, so both of us, we came to do a turnaround piece in Mount Vernon, but Mount Vernon is a really big cancer center. And again, even more closely with cancer alliances. So I guess by default, I've ended up in this role, and I guess I've done all of the roles leading to get into a specific role that allows me to focus on this. But throughout my career, you get to see the impacts of cancer. You get to see, the you get to see the inequalities associated. You get to see the impacts on patients' lives. When you sit in some of these mortality meetings with all oncologists, and you start to hear some of the stories, it becomes something quite personal. To be honest with you, it really becomes something quite personal when you're hearing kind of oncologists give you a profile of a patient, and you start seeing that actually the 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 view that I personally had of cancer, which is it's an older person's disease. How naive I was, trust me, how naive I was. You start to see when you're working with the oncologist that it actually has no specific. There isn't a specific bunch of or group that it targets. It's anybody.
Yeah.
And so
Yeah.
when you're seeing that and you're seeing the impacts on families, and it's like it becomes really personal, and you really want to be able to impact that. So whilst working in hospitals, I was able to impact on a more on a smaller scale. And I always looked at the alliances as a place where you can impact a larger population. And most importantly, because we're looking at population health, we're looking at, we're looking at other aspects of dealing with cancer. Whereas in the hospitals, we're dealing with the cancers coming through the door. So I really, really wanted to be a part of that. I've always wanted to be a part of that since the alliances were set up. So I guess by default, when this job came up, I was like, "Oh, I'm definitely going for that. 100%, I'm going for that." And I haven't looked back, and I haven't regretted it since.
It's so interesting actually because I imagine working in a number of hospitals, like you say, you have done. I imagine that gives you a really good overview and probably, as you said, it kind of like feeds that desire to want to bring it all together.
Yeah, yeah, it really, really does. But it's like the frustration for me whilst working in these very important roles, and I would say they're very important roles because anything that we do in healthcare is important. Um, but working in those roles, I just wasn't able. I was able to do a lot, and I was able to do a lot locally, but at a much more larger scale, because I think the fight is larger. It's, it is about, what we discussed this in many podcasts and through other discussions that we've had. It's not one size fits all. And I guess it's that approach that you can have at an alliance level, where you can start to look at things on a more, actually, what does our population require? How do we engage far better with our population? And then you can then start to change and influence how cancer services work within these specific, for a larger population.
It's a heck of a job, Femi, you've got, but more broadly, the alliances have got in bringing it all together. Because I mean, you'll know from working in hospitals, even within a hospital, there's lots of different computer systems, for example, lots of different ways of doing things, and then the alliance has to bring all that together across different hospitals, and it is a heck of a job. How would you kind of describe your job, your role within that kind of bigger piece?
I think my role is to pull the program, and when I say pull, it's not only me working with a massive team of, a team of specialists, clinicians, specialist program managers as well, and program leads. So I've got the most amazing program leads working with comms. So we know Paul's somewhere in the background lingering, but working with everybody within the system and the various different organizations to pull it all together is a massive part of my role. So bringing things together to deliver the greater, or the bigger picture for the population, so the wider strategy for the population, that's part of my role. Also, kind of creating the strategy for cancer for our system, based on our population health. I'm working with GPs and everybody that's involved in that delivery of cancer care, and create, delivery of cancer care within our system is something that I do. So I bring people together with my team. So all of us collectively, we bring people together, and we try to take a more targeted and more coordinated approach to delivering cancer services across Northeast London.
What are some of the biggest challenges? Because I mean, you've sort of touched on a couple already. The challenge of bringing together all these different services, bringing together different people, different ways of doing things, different ideas, and things like that. But what are, from your point of view, what are the biggest challenges that you face in your role?
I think the biggest challenge, because my role is also very, we call it transformation. So we do all of the transformation improvement in terms of, delivering the fun stuff, the real, actually, how do we change a pathway? We do a lot of that. And I think one of the difficulties that I found, particularly at the beginning of this, but it helped that I came from, from secondary care, I guess, is it's the engagement with secondary care, with GPs, with everybody in the system who have got scarce resources, scarce time. And how do you bring them all together to do a transformation, to deliver a transformation agenda for cancer whilst they're really, really busy, fighting that fight on a shop floor, and delivering the services on a shop floor with, with all of the pressures that come with that. So I think it's the engagement and bringing everybody together to deliver that has been difficult. Was difficult, especially when I started. So it's difficult and it required a different approach. I think that's probably one of the most challenging parts. But also, it's that, why should, hospital directors give me any time, or why should GPs give me any time? I'm just another, as far as they see it, as I'm just another manager, just trying to perhaps try to get their time and try to tell them what to do, and and focus on areas where they haven't perhaps got things. Whereas actually there was a lot of convincing that that's not what my role is. So I think there's the initial engagement with teams and building the trust across a system is especially a system where you've got different people doing different things with different priorities, was one of the largest challenges to this as well, and the limitation of funding and everything else that goes with it.
So how do you get that engagement then? If you're just another kind of manager coming to people in various hospitals, from a very new alliance relative to some other alliances, how do you engage them and get them on board with what you're doing, or how have you done that?
Well, we've done that, and again, it's definitely not me. I say we have done that through literally taking those engagements to where we can. So as opposed to, for example, even just how we generally communicate. So instead of having, virtual meetings, we've gone to the hospitals, we've gone to clinics, we've had meetings with clinicians outside of their clinics, we've gone to boards, we have gone to where everybody is to have those discussions about cancer. And then what we've also done as well is we started this a couple of years ago. We really started to focus on showing them the collaborative work that's been happening across the system. So we've been utilizing our webpage. So we spent some time enhancing our webpage, because that's also another channel for us to communicate. We started to utilize our social media far better than we've done before. Then one of the key things that people couldn't deny is that actually, as a Cancer Alliance, we talk to our communities. So my team literally go out to the community and work with the community to deliver campaigns, to have conversations. I mean, we go to local, they're called scrutiny meetings, but they're like council meetings, to discuss specific issues to specific boroughs as well. So we've been doing that engagement, and that engagement has forced everybody, I guess, to work with us, because if we're working with the people who we care for, then the providers and GPs and everybody else, it makes it easier for them to have those conversations with us, because we're literally out there. We are where they can't be, because they are physically delivering the work. So we're delivering the work as well, but we're just delivering it differently, because we actually can build into our work plan the engagement piece, which is huge.
That's the beauty of alliances, isn't it? In a way, because I know yours is fairly new. Others have been around for a little bit longer, but it seems to me that going back a few years, when I've had dealings with the NHS, when my wife was unwell, having her cancer treatment, there isn't a lot of the NHS that's very joined up, and I know it's getting better, but the alliance plays such a really important role in joining the dots for patients, doesn't it?
It really, really does. I think I'm working in this space before, these alliances existed. I think it is one of the best moves that the NHS has ever made, and it's delivered. I mean, the investment in cancer alliances, which was hundreds of millions, it has delivered. If you take a look at the cancer performance against all of the other, I'll call them programs, just easier way to kind of follow what I'm about to say through. But if you take a look at our, as in the national program for cancer, versus elective versus urgent care, the Cancer Alliance has delivered in terms of the reduction of the backlog for patients waiting over 62 days for cancer treatment. It has improved earlier diagnosis. I know it's got a very ambitious plan for that. But again, I mean, our dial has moved up, a couple of percentages, which is huge when you take, the real number into consideration. And in terms of diagnosing patients faster, we have been able to do that. I mean, we have consistently been able to diagnose our patients faster. We've also ensured that once our patients have been diagnosed with a cancer, that they are predominantly treated within 31 days. So I think there's a huge amount of work. And this isn't just us in Northeast London. This is the cancer program in itself. It is delivered on the standards that it's set for itself, that it's set, which is quite ambitious. It delivered on its standards for last year. And I think, dare I say, I'm knocking the other programs, they've got huge challenges as well. But the investment in cancer alliances, in the partnership of working with providers and working across an entire system, has really brought results that has been global.
You've sort of touched on a couple of areas there that we've we've really dug into during this series of episodes. Things like early diagnosis, health inequalities. Um, just tell us about some of the work that you're doing in some of these areas at the moment, currently, but also the work's coming up in the future.
Yeah. So again, as you know, some of our campaigns have, they've been, um, they've gone for shortlisting for awards. They've won awards. So our campaigns in terms of engaging with our community is an area that we've been focusing on. We've always focused on. Cancer alliances across the patch do this quite a lot. We do it a lot as well. The difference, I guess, is that we got a very diverse population, as you know. So therefore, it's we have to really tailor some of our work to meet um, to meet the needs of our population and to ensure that it's there are campaigns that people can relate with. So, for example, our You Need to Know campaign, which is a campaign to increase awareness of womb cancer amongst Black and African and Caribbean and South Asian women. We've got another campaign, which is It's Not a Game as well, which is a campaign for prostate, bowel, lung, and stomach cancers. And again, we use things like sports to engage with men. We've used campaigns where actually we've got women of ethnic minorities actually talking to women to encourage them to present and to encourage them to, bringing aware of the symptoms and encouraging them to present to their GPs. It's some of these campaigns help us to tackle that inequality that we have across the patch. We know that we've got language barriers. We know that we've got a very diverse beliefs in our community. So therefore, tailoring some of these campaigns to do that is something that we've been able to do successfully over the past year and a bit over the past year and a bit. I mean, another way that we've been tackling inequalities as well. We've got some of our targeted. We've got our. I mean, it's a national program, but again, targeted lung health check is another program that we have. And again, what some of the work that we're doing there is to support the diagnosis of cancer far earlier. We have tools in place to support that, where we've got leaflets and in various different languages that goes out to patients. Even our websites as well, in terms of how we use that as a tool, is also something that supports us to engage far better and to help to reduce that inequality across our patch. So I guess we're using various different tools to 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 reduce the inequalities in our patch, but also we've also got vans where we carry out diagnostics vans again across our patch as well. So sometimes we take that to places where we know that we're going to get the most amount of uptake. So there are various different things that we're working on, or sorry, it's like we're doing now and we have done to try and reduce inequalities across our patch. Some of the things that we do want to do for the future that I want to focus on is a lot around technology. Um, and again, our use of technology, which we've already started as well. So we've got AI chest X-ray. So we're going to be using AI in that. We've got a program that is going to pilot the use of AI in that. But the use of technology also in the back end of how we manage our cancer services is also crucial, because what things like that do is release time. So we're also working with both private and private providers. We're working with other cancer alliances and adopting their best practices to try and look at how explore and actually work on programs that uses technology to enhance the work that we do, releasing time, but also to try and identify cancers far earlier. So I think that there's a lot more in that space that I personally have a massive interest in, and we as a Cancer Alliance are focusing on in this year and the next.
Before we dig into the sort of AI technology thing, you've beautifully trailed some episodes that we've recorded together, haven't we? We talked to, for example, we talked to Steph all about the lung targeted lung health
Mm,
checks. We went to Maggie's. We talked about some of the health inequalities that they're helping to overcome. We talked to Pamela from Black Women Rising about some of the health inequalities that she's faced. Um, Karen Hobbs back at the start
yeah.
talking about the You Need to Know campaign. All these things are really engaging for for that specific audience, and I think that's something that I've really picked up as is how targeted your programs are to a specific audience, to a really niche audience, and that's the kind of key to getting to those people. Going back to technology, artificial intelligence is something that you hear a lot, related to cancer treatment. I know there's a lot of work going on around things like lung X-rays, aren't there, with AI?
Yeah.
Is it something that you think we need to, or there needs to be a big education piece on for the wider public? Because it strikes me that AI, there's a bit of sort of inbuilt skepticism, isn't there, with trusting technology over something so serious.
There is, and I think it's perhaps how we look at technology, to be honest. I think if we take a look at it as a assistance to the professionals in the field versus, oh my God, the AI is going to take over the world and the AI is going to be the solution to everything, then it allows us to be able to work with, to allow it allows it to do what it's intended to do for us, which is to provide that support whilst we focus on the more complex areas that we need to focus on. And even if you take, actually the identification of cancers as a prime example, you're still going to need the specialists in this area to manage all of this. So this is just releasing their time to work on more complex or more complex areas of work. So I think it's how there is an education as to, first of all, I don't think that AI is going to save the AI is not the savior. AI is the assistance that's going to help the NHS and its professionals to deliver care. And I wouldn't necessarily to deliver, it's an assistant. So I think if we look at it in that way, then I think it's easier for people to work or want to
Yeah.
work with systems that allow us to do that.
That's a really good way of looking at it, actually. As an assistant, rather than, I think in some walks of life, people are expecting to be, AI to come in and take over. I was chatting to a student yesterday. She was 17. She's doing her A levels, and she said all the students are just hitting, AI on the internet for their essays and things like that, and it's just doing their work for them. And I think it is important in this area to think of it as an assistant, isn't it? Because the people looking at the X-rays, interpreting the results, they're the ones who are going to determine, what happens after that point.
Absolutely. It's the support processes that are efficient, but it's down to the leaders or the professionals in this particular in a specific area to manage it and train it to do what they need it to do for them. So I mean, AI has, or machine learning, whatever we're going to call it, it has many benefits in healthcare. I mean, for example, one of the things that I want to do with the machine learning subject I mean, I want to do across various different areas again as an assistant. But one of the key things I want to do is, for example, the analysis of data faster. So we can analyze data as humans. It could take us a while to analyze it, and if we, if we work in a specific area, our own brains as AI will immediately allow us to be able to factor to understand things a little bit better just from experience. Now, one of the problems that we've got across our patch is that we do have data. Data is in various different places. Now, if we can have the support of machine learning, and we can teach our machines to learn a little bit faster and pull that information for us a little bit quicker. Uh, it just gives us earlier access to the data that we require, and it allow us to interpret it the best way we can. We still need a human factor to, and after taking that knowledge, what are we going to do with it? So some of this will help us to create new targeted projects. So again, I want to use AI in our patch to be able to, for data as a prime example, to help consolidate our data a little bit better. There is some skepticism around that because this is NHS data. We can't just allow AI to just roam freely,
Yeah,
and especially if
yeah,
it's open AI, we don't want the relevant information to just be out there. So there is a piece around how do we work within the environment and the governance within our organizations to then mine some of that work in a very secure way, to enable us to get the information that we require a lot faster, and to not interpret, but to pull meaningful information far faster than what we can. So you're right, there are skepticism behind AI, especially around data, I would say,
yeah.
and how it's used beyond the environment to which it's supposed to be working in. But also, I think there's some benefits if controlled and if used sensibly for us to gain some real benefits. And the example of the data mining, or should I say, sorry, information creation that I've just described, is just one example of how that could be done.
Tell me a little bit about intelligent automation and how this is going to help you guys work.
Yeah, so again, intelligent automation is something I think will help us in the back offices. So, give you a prime example. NHS organizations, all NHS organizations have multidisciplinary teams, and they have multidisciplinary team coordinators. Those multidisciplinary team coordinators are the back end gentlemen and women, that help from the initial referral right through to treatment. They help manage that patient electronically in the background on the cancer pathways and the various different cancer pathways. They prepare the patient's case files for discussion at multidisciplinary team meetings. And they also ensure that the results are back on time, and they really help to drag the patients through the pathway to ensure that they receive their treatment on time. Now, over the years, there's been so many things added on to that function. So we've got audits, we've got various different things which are really important, but they've been added on. They've been added on to some of their workloads. Now, if you take an example of what they have to do, they have to go through various different systems to collect information. Well, if you can mimic, and this is what the robotic automation can do, or the potential of robotic automation, if you could start to mimic some of the work, I mean, you can't do all of the work because some of the work does require, a lot of the work does require human intervention. But if you can take some of the work that is repetitive and is cumbersome, and you can streamline that through robotic support, well, what you could then do is release their time to focus more on some of the other aspects of the MDT coordinator's role, that requires a human function. So therefore, you take away a little bit of pressure, and of course, a robot could look at various different systems 1,000 times a day, whereas a human being can only open certain amounts of things, and do different things certain times a day. I feel that by introducing things like robotic automation in the background to help administrative functions, one of the key things that you could do with that is that you can reduce the pressure, release some time, and allow teams to focus on much more human required areas of work. Whereas
That,
right now they are massively pressured.
that's so important, isn't it? Because I think to a patient, you might you might want all your focus to be on really patient facing stuff, but actually there's so much work going on in the background that does impact patients. But I wonder if maybe when times get tough and your money gets short and manpower gets reduced, those are the bits that maybe get neglected a little bit, but they are
Mm.
just as important, aren't they?
Yeah, they are, and some of these areas, because they are, the NHS is it's been faced of it's a victim of its own success, in that it is so successful that We've got much more complex cases that we're managing, and therefore these administrative functions in the background and the scarcities of monies and reduce and the need to reduce wastage within the NHS means that people, organizations are investing more in clinical resources in place of administrative resources. And there is a we can't forget that the administrative resources are so important because, like I said, we've got all of these systems, but these systems don't do anything without the people doing something in the background with these systems. And they help to get the patient from A to treatment and as quickly as possible. So they are so important, and I think at times it is about absolutely we do need to invest in clinicians, we do need to invest, but we also need to find solutions then to the back end that helps to yield the work that's required at the front end.
Um, you said at the start you've worked in the NHS for more than 20 years. What's still driving you on a daily basis? What are your passions? What makes you get up in the morning and go to bed with clearly the enthusiasm that you've obviously got?
To know that we are impacting a population's health, that the work that we're doing is it's indirectly and directly saving lives. I think that's the crucial part to this because you know we've all been affected by cancer one way or the other. So to know that we are able to give our part back to society to help to reduce the amount of well, I say reduce, detect patients who have cancer a lot earlier and treat them a lot earlier is a crucial part of I say, I think it's the most important part of one of the things that we do here. So I think that's a driver. It's a massive driver to know that actually one way we're contributing back to a population. And for me, I'm lucky or blessed, I'd say, to be able to work in this role and be able to work in an area where we have the most diverse population in London and be able to contribute towards the challenges, and cancer is a major challenge that they face for this particular population.
When you engage with healthcare professionals in northeast London, just to kind of wrap this all up, what, if any of them are listening, now to this podcast, and you've got a message to them, when you're engaging with healthcare professionals, what is your ask? What can your colleagues in the NHS in northeast London do to help you, to help the alliances work?
I think they just need to really work with the alliances. We are a friend to. We're all in the fight together. We're all in this, and I say, is fight the right language to use? I think we've had a conversation about this, but we're all in the service of delivering cancer care to our patients. We all have different roles to play, but we all need to work together, and we do work together. But we all need to continue to work together to deliver that for our patients. And I think the benefits of what the Cancer Alliance does is that we do bring together everybody to deliver this. So I think it's just continue to work with us, continue to support us to deliver our programs, because when we pulled all the pictures together as we did earlier on this year in our launch for 24-25, one of the key things that we saw is that actually when you pull all the work together, we're doing a great piece of work for our patients in Northeast London. So I think it's just that continue to engage with us, continue to work with us as a Cancer Alliance, so that we could deliver the bigger picture for the system, for all of the patients that live across London, for all the patients that live in England, really, because all Cancer Alliances collectively are doing that.
That's actually maybe a good way to end. But looking at the whole country, I don't know. We can cut this out if you don't want to answer. But I don't want it in any way be political. But obviously, we have a new government, and lots of people for the last few months before the election were calling for a national cancer strategy and that kind of thing. I just wonder if I can ask you kind of where you think we are as a country in terms of things like waiting lists, things like getting rid of the backlog. where we are and whether we do need this big, this big overarching strategy?
I think it's always helped to have a strategy. It always helps to have a strategy. I think that's the first thing, because what are we trying to deliver over the next 5, 10 years? And then what are the key components that we must deliver within that, or objectives that we must deliver to do that? So I think, one, having a strategy is vitally important, because we need a clear direction of where we're traveling to. I think also strategies are very ambitious. And I think setting that bar quite high is very important, because we're all trying to deliver and achieve worldwide services. So the answer number one is yes to strategy, I think is important. And I think every government that we have should definitely ensure that there is a strategy that is aligned to delivering the best care for its population. Two, in terms of backlogs and waiting lists, and you know like I said, I think I said earlier on, and forgive me if I'm using the wrong word, I think the NHS is so amazing that it has become if it's the right word, and I'll probably get beaten for this terminology, a victim of its own success. We set out to have a national health service that's free for all. We started to introduce technologies into this, and drugs, new ways of treatments, and now people are living longer and longer and longer. Obviously, over time, what's happening now is that of course you got more people to care for, you got more people to treat. So things like backlogs will unfortunately exist, because the number of people that are now requiring care versus the people delivering the care is, it's going to be, there's always going to be more. However, the strat, and I can only speak about I only want to talk about the cancer part, because there's urgent care, there's elective care. But I think that the same level of engagement and the same level of commitment for cancer is crucial, in order to for us to start to reduce, or start to reduce the amount of complex cancer cases that we have in this country. I think there is a need for the government to continue to invest in cancer alliances, continue to invest in cancer services, and providers in delivering that, and new technologies to support that. So, I hope I haven't said anything political. I don't think I have. But I think this is vitally important for governments to continue to do that. But I don't think any government that comes in, to be honest with you, I don't think any government that comes in, I mean, everyone's impacted by cancer. So I think any government that comes in, it will immediately look at, delivering care and delivering the NHS dream, which is now more complex to deliver. But, the investment in that is crucial. I'm not sure what they're going to invest in cancer, and I'm not sure what the strategy looks like, but it needs to have the same level of engagement that we've had, and more investment, to be honest, for us to be able to do more for our population.
Femi, thank you so much for talking to me. That's so interesting. I know if you haven't heard the other episodes that Femi's been involved in as well, make sure you listen to those. Femi, thank you so much.